If you've got it just right, and you can do this in the peripheral joints certainly, as soon as you squeeze them and you just go in a circle, bang, 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 everything frees. If you can do that all day, it won't do it. That, and it'll change.
Yeah.
And the wrist particularly, you can do that, hold the wrist, go around, and it makes such a noise. Oh, that's better, straight away.
Yeah.
But the key to that is the compression. And most manipulation, you not want some compression. And that's the one thing that people don't realise.
Yeah.
If you're watching it done in the lumbar spine, lots of pressure. In the neck, lots of pressure. Peripheral spine, lots of pressure. What? Not long, but a tiny bit of pressure increases the focus.
Yes. I suspect it wouldn't hold up well in the PCC if someone complained about me, but my own experience of having my neck manipulated began when I was in my 20s, I think, and having woken up with a blinding pain in my neck and been to St Bart's and given ibuprofen and sent away, x-rayed, nothing wrong with you. For 2 years I couldn't turn my neck, and you know you can't turn that way because that's what you need to do when you're driving a car, isn't it? You can cope with it not going that way. And then I went to someone 2 years, it was almost 2 years to the day I think later, and it was for something else, and he fixed me. He said, I can fix your neck as well. And I said, well, all right, and with one crack. And instantly it was better. I was so bloody angry. I thought, for 2 years, the NHS told me there's nothing wrong with my neck. And he's even angrier because he was a physio, not an osteopath. So I'm sure it wasn't minimal leverage, but it worked. No. Right, where do we get to on your list of why we would be doing this?
There's a large psychological effect. If you do a thrust and you get something gives a tiny pop, a very, very slight one, and you can see me doing lumbars here, that is interesting. There's a famous story about one famous osteopath who's long dead now, as most of my generation are. I'm 81 now, and that's interesting. And he went to visit somebody in London. He just qualified. He walked into this block of flats. Oh, yes, it's you. Can you pop my back? No. I must... don't bother with the history. Let me pop your back. So eventually he had the patient sitting, pulled it, bang. Oh, everybody's done that. That's a lot better. Thank you very much. Have lots of money. Go off. He got his pen out. Ugh, there's ink everywhere. It was the pen that snapped. No banging his back at all. It was the pen. And the chap felt better. Well, fair enough. If you can do that, that makes a difference.
Yeah, and all of these factors are really important. But of course, the conventional medical world doesn't want to know about this, really, do they? But the fact is, only in my case, and we can think of lots of other cases, for 2 years it did nothing for me, whereas you would have fixed it instantly. Somebody did fix it eventually. And during that period, I and lots of other people are going about with disabling restrictions, which they needn't have. What would you have said in your defence had your sister complained that her disc blew while you were treating her?
Sometimes it happens, and I'm very sorry, but it's just the lying on the table, just turning you, and the thing went. Yeah,
which of course any of us here would say, well, if it was that ripe to go, it was going to go at some point. Again, you'd have to justify that in the court perhaps, but with 70,000 cases behind you, you can probably get some fairly good evidence for that. Dave says, what does Laurie mean by get the conditions right when the thrusts don't result in symptoms permanently ceasing?
I think the thrust has been effective in opening the right joint. If you're that accurate, that's fine. But unless you've improved the joint's function, which you know as soon as you've finished, you don't get the change you want. And if it comes back, that was an incidental. It's not the cause of it.
Okay. And JJ says, how do we accurately explain what the risks... Oh, this is a good question. How do we accurately explain what the risks of a cervical HVT, for example, or others without putting the patients off? Did you get people to sign forms before they had treatment?
No. When I qualified, you said to the patient, now, that's the position. I'm going to give this little foot thrust. You may feel a slight noise. Don't worry about it. Before they had a chance to think about it, bang. Oh, and that was it. No problem. But nowadays you have to have a signed thing for every procedure you do. And I think the pendulum has swung too far that way. It'll come back, but it takes time. And at the moment, everybody's very cautious.
Yeah, I would just want to reassure the audience here and those online that yes, you have to sign your notes, and it has to be in your notes that you've got consent, but you don't need to get the patient to sign a consent form for everything you do. It's got to be in your. If it's not in your notes, it didn't happen in the eyes of a court.
Yeah.
But oral consent is absolutely fine. And we've done some shows about oral consent because it's so important, and what abbreviations you might want to use. And some people do use a signed consent form, which it serves the purpose of showing your intent.
Yeah.
That you are getting consent before treatment, but actually it holds no water in a court at all because consent is an ongoing process.
Really?
And we've got to bear that in mind. It's not very quiet, aren't they? Any questions from our audience here yet? I think they're all frightened of the spotlight. Again, another good question. CB says, how wary are you of manipulating around a damaged disc or a recovering disc?
Yeah. I used to be very nervous. The first 10 years I didn't do it. I was scared it would damage them. But then I started to get the contraindications in mind and discovered using minimal leverage, if you release the facet without straining the disc, instantly they're better because the facet is free. And occasionally they do react because the thing swells a bit. But now I've got no problems. Even an active disc, if I can get that in position, I'll apply the thrust. And I discovered something else with lumbar technique. If you wind them up and it hurts and you can't do it, have somebody just pull on the lower leg. And as they're pulling, the thing winds, and often a tiny thrust, the joint goes, and instantly they're better.
Yeah.
And I had people doing this in the clinic. I call one of my colleagues in, just tug on that leg, and bang, it goes.
How the hell did you discover that?
Purely by accident. Right. I had a patient who was a judo player and I couldn't get to it, big burly guy, and I got it in position. And my wife was there, and I said, just try that, pull on the leg. As she pulled it, it went. And that developed from there. And I think these big burly guys, they've got everything overlapping. A little bit of traction and it goes.
Yeah.
So a lot of compression, but also traction.
We need to move on. We're going to do some demonstrations in a minute, but before we do that, let's talk about contraindications, because of course those are absolutely key to the screening process, I imagine.
Contraindications, there's lots of them, and the students know them intimately. But
shall we test them?
Yeah, why not? Anything that can damage bone, anything that's weak in that bone, you don't apply a thrust. Anything that affects the neurology.
So when we're saying about weakening bone, we're talking about metastases or
metastases, anything like
osteoporosis.
That is a big problem. And I had a patient of 102 came in. I thought, oh, this is nasty. Positioned his neck, it went bang, and I left it, and it was better. So I'm not concerned about that. If you use minimal leverage, you're not going to get problems.
Right.
That is a relative, not an absolute.
Yeah.
Anything that affects the vascular situation, somebody with pins and needles in the hand, or they've got obvious circulatory problem, you've got to be cautious with that. So position it. And this is where 3 comes in. 1, how's that? All right. 2, how's that? All right. 3, yeah. If they're not getting worse, carry on.
Right.
Because that's a safety thing as well.
Yeah, but of course we would be looking to address a problem of pins and needles in the hand, wouldn't we?
Exactly.
So it can't be a complete contraindication.
Yeah. One thing a lot of physios do that use manual therapy is they use recipes. And this is something osteopaths don't do. We've got specific things that we use. We don't have a recipe. If you've got this, I'm going to thrust it. And that's one thing that physios they're taught that, and that I think is wrong. They're not taught the manipulation, how to position it. I can't get that right, I'm not going to do it. They just carry on. That's a big problem. And that's where you get lots of problems. People are over.
Yeah, and you emphasise this on your course, don't you? That you don't apply recipes. Address the patient in the room and the history that comes with it.
That's right. Yeah. And you need some sort of tissue diagnosis. You need to have some idea what's wrong. If you've got a segment that's stuck, release it. If it's not stuck, there's no point doing a thrust. You're not getting anywhere. So you need some sort of diagnosis. And the last thing is symptoms. As you're winding it, if they're making a whole fuss, you stop. You don't say, I know best, because that's a big cause of problems.
Yeah, I had one of our members sent in a problem to me recently, which I don't think we've discussed in one of our case-based discussions, but it was a patient from another practitioner. And the patient said that the practitioner had done exactly that. No, it's fine. I'm going to manipulate this joint. Hey, it hurts. Don't worry, it's fine. And she said the patient was in real distress about it, and she didn't know what to do, whether to report that practitioner for, breach of the osteopathic practice standards. Damn, I've given away that it was an osteopath. Or maybe just have a word with the osteopath themselves. But it was clear that they were doing what you just described there. It's just not listening to what was happening under their hands.
Yeah, that's too much confidence for the wrong reason.
Yeah. Jenny says, how do you feel about HVTing osteoarthritic joints that are never going to have full ROM anyway?
You will often get, you're releasing something that's catching around the joint. If you're using minimal leverage, you'll not take it to its final limit. Using what we did in the neck, looking at the position, you can get that to the point where you can apply thrust, which is not straining the joint. If you can do that, then you do often get a very good relief, yeah.
Just there's one more here before we go. Redkev says, I was taught that after you were happy with the patient's screening, just whack the joint with an HVT. And he says he never got on board with that quite. Over the last 14 years of practice, he's come to rely on adding vectors to the area and limits his pressure and always starts with gentle stretch and compression. And most of the time the joint releases. He says he's not sure if this is short lever.
I don't know, frankly.
You'd have to see the technique, wouldn't you?
Yeah,
That's what he's doing. And applying stretch and compression doesn't really affect the levers for the manipulation, does it?
More compression, you've got less levers because you're holding it. Yeah, but I don't know with that one.
Yeah.
No.
Just a moment ago, I asked you about treating an osteoarthritic joint. I think you have an example of having attended a conference with somebody who had an osteoarthritic hip, which was about to be replaced by a surgeon, don't you?
Yes, I did. I was in America lecturing there, and they asked me to look at one chap who I knew quite well from previously. He was 54, and he had a tight hip. And he came out, and I looked at him in front of everybody, and I said, I'm sorry, you've got arthritis here. I can't turn it inwards, and it's very tight, and it's creaking.
And he had a hip replacement scheduled for very soon, wasn't it?
Yeah, the next week to have the hip replaced because he had quite bad arthritis. I saw the x-ray, and it was bad. And I said, I can't do anything with it. I can ease it, but it's not going to make a lot of difference. Does anybody here know something? And somebody at the back said, can I have a look? And he had a look, and he laid the patient on his back, moved one hip forwards and back. The other one was tight. And he said, look, that's tight. He laid the chap on his side. He said, I'm going to give you 3 bangs on the bum. And he did that. First gentle, then harder, and then everything. And the chap instantly got his full rotation back. He got off the table. He said, that's fine, thank you. And I emailed the chap the next week, what's happened with the hip? Oh, I cancelled the surgery, I'm better, I'm playing golf now.
So you haven't cured the arthritis?
No.
But
It
he's
would
got
still
that,
show
that range of motion back.
The hip's back to normal.
Well, I hope that description hasn't put off our first model for the evening. Rebecca, can we borrow you perhaps? And let's have a look at this.
This is a very useful technique that people use in practice, and it really does work. Let's get this off. So, come over here and I'll show you what we do. Right. So, just come and stand here for a minute, and let's just go through what we're doing. So, you've got tightness in the hips, yes?
Yeah, restricted internal rotation on both sides,
Yeah.
chronically tight glutes.
Yeah. When did it start?
For as long as I can remember, but
Yeah.
a couple of years ago I sort of tore my hamstrings and some gluteal muscles,
Yeah.
and it's sort of gotten worse from there.
Right, okay. And have you had it treated?
I've had sort of SIJ treated, and I've tried to do a lot of mobilisations myself, but I haven't had any work sort of on the hips.
Right, okay. Right, come and lie on your back and let's have a look.
Now, the audience in the studio aren't going to see much of the range of motion here because they're at the wrong angle, but the overhead camera will get it full.
Yeah.
Hopefully we can put that on the screen perhaps.
Right, let's have a look at this one first. Have this bent to 90 degrees. Her internal rotation is limited, no question. And if I push that harder, it doesn't go at all.
No.
This way, it's reasonably good. So that's pretty well normal. This side, which she said before is the worst, if I try and rotate that, that's all she's got. And I'm not forcing that. It won't do more than that. Okay? I'm holding that, and that doesn't go. This way is normal. So that's reasonably good. If I take hold of the greater trochanter and move that, that's tight. This side, well, there's no movement at all.
No.
So this one I think we can change straight away. Lie onto that side with your back to me. Have this leg just resting in front of the other one, just resting there. That's it. Now, I'm going to give you 3 bangs on the bum. Nice long stance here.
So you've kind of got a 90-degree flexion of the hip there, just resting there, and you're at 90 degrees to the femur, more or less.
I'm at 90 degrees. That won't work. That won't work. It needs to be 90. Hold the anterior spine, nice long stance, and take a gentle tap forwards. Okay? Is that all right?
Yep.
Good. Bit harder. Okay? That's it. And right. Lie onto your back. I haven't done anything else, just done that. Let's see what that's done, because if we're right, that should have immediately made a change.
It feels less tight, to be honest.
And it's still going, and still going, and still going. Now, I don't know if you can see that. It's a lot more than it was before. Let's see that one. That's pretty good. That should be better. Just try walking up and down on that. See how that feels.
Oh, you didn't warn the camera crew about this.
No.
Rebecca, could you stay as close to the backdrop as you can for this?
Want me to walk behind the couch?
No, just as close as you can there. We need to see the bottom half anyway, so.
Better or the same?
Feels like I have more extension available when I'm like striding.
Right, let's do the other side while you're here. Come and lie onto your right side. Yeah, take that out.
Sorry, no, it's attached.
Fine, okay. Now, this time you get a chance to see this again. Holding the anterior spine, forwards on the greater trochanter, and I haven't done anything else. Normally I'm doing soft tissue, articulation, so taking that forwards. Forward. A bit hard. Coming back again. This should have increased quite substantially. Yes.
Laurie, you've unplugged your mic apparently.
Oh.
Let's, if you can find the other end of it, something's, yeah, it's come undone. There you go.
That's better. Right, sorry about that. Yeah.
The miracle of the voices in my head.
Yes. Now that's a lot better than it was before. And that should do you a lot of good.
So, when I said that I missed a trick with the title for this show, I said we were going to talk about forced thrusts and smacking your patient's bottoms.
Yeah.
And there's an element of seriousness in that,
Yeah.
because when you describe to your patient what you're going to do, it's very easy to be a bit facetious about a technique like this. And, you know, I have done this. I've said, I'm just going to smack you on the bottom a few times. Now, that's with most patients, you get away with that, but
Yeah.
you only need one. And, you know, you've got plenty of experience of others probably, and maybe yourself, with people hearing things differently.
Yeah.
And we had a complaint recently from somebody whose patient clearly had not heard what they'd been saying in the clinic. So you need to be, I think, with a technique like this, because it's quite a weird technique, isn't it, Rebecca? You need to be quite clear about what you're doing, why you're going to do it, and not joke about it.
Did any of that hurt when I did it?
No, not at all.
No. Not
It
at all.
feels when you're applying that technique, you think it ought to hurt, though, don't you? And you get a bit worried, especially with an elderly patient, about how fragile is this hip.
Yeah. If I'm hitting it and staying there, that's going to hurt. If I'm doing that and sliding off, it doesn't hurt, because the impact is what does it. It's the impact that makes the change.
Right. Thank you, Rebecca.
Fine, thank you.
Right. So should we go on to the second technique?
Yes, let's have our subject come out. Cameron, please.
Now, this one is, the last technique there is something that you can probably take away from this demonstration, and as long as they apply the principles, 3 or 4 of them that you described there, easy to have a go at in clinic. This one is a proper demonstration of minimal leverage technique, I think.
Yeah, come and sit with your back to me, please. Let's just have a look at your neck and see what's going on. Occiput is a strange joint. When I was a student, we learned 8 different positions it can be in. Yeah, you're a little bit tight on this side. Do you get headaches?
I do.
Yeah. Interesting. How do I say that straight away? Because if you've got a problem with that joint, you get headaches. You'll be better after this. We're not charging for this, are we? Right, continue.
Donations will be received.
Yeah, take your glasses up. Now, turn your head a bit there. That's it. I'm fixing in front of the atlas there, and I'm pressing against his shoulder. And normally I'm not talking because he can hear that through there.
Pressing on his shoulder?
pressing his shoulder. Lean against me. That's it. That hand comes round there. I'm taking him into side bending, extension, pulling back on the atlas, little circles, bang. Now, did that hurt?
No.
No, it's a shock, certainly. Is that tender now?
That's good.
That's crazy, that. And what I was doing was tiny bit of rotation, no more than that. It's not round there. This is halfway. I'm holding the atlas, coming around there, gripping. I'm taking my hand and change. That's side bending. Little extension, pulling back on the atlas, into circles, and then both elbows back. Let's just show you the other side to see that a little clearer. Taking the head there, holding the atlas, coming around there, side bend, extend, pull back on the atlas, into circles. That's the position. I'm not going to thrust this side because it doesn't need it, but that's the position. And what that's doing is shifting the atlas, taking the atlas backwards. But if there's a positional factor, it's right, whichever. It just sorts out. It's very strange.
So we didn't show the slide earlier on, but you said with the spine, normally you'll do 3 repetitions before you thrust. Is that what you're doing with the circling part of that technique?
If I'm there, I'm just going to hold this there. If I'm there, and I try and do it from static, I can't accelerate. So I'm circling 1, 2, and I'm doing 3, yes. That's the same as anything else. You're winding the neck up, gently take it to its limit, 1, 2, 3. That's taking the joint to its...
You went to a conference once, didn't you? A physiotherapy conference, I think, where they said they wanted you to speak, but you said you weren't allowed to do HVTs.
Yes, yeah.
Do you want to tell the audience about that one? Because I think, again, it's quite revealing about people's approach to HVTs and their preconceptions.
That was in America, once again, where if you're thrusting things, you're in real trouble in this particular state. Anything in the neck, no thrust above C2. And my wife had headaches, and I did that one. Oh, that's all right, that you can do, there's no danger. And after that, they're now teaching it, because they've seen it's not dangerous. If you're doing the traditional stuff, possibly that is dangerous, where you're going in like that. So if you're doing that gently, but if you're trying that, what was I introducing? Which foot is backwards? That foot's backwards. That's holding the front of the atlas, taking the head a little away into rotation, pulling that back. This hand, thumb is right up there. It's not there, it's there. This hand is coming over there, gripping the head into me. Dip into flexion. What else? Extension, side bending, extension, compression. And that's the position. There's tension, there's tension. If you leave out the side bending, it doesn't work. If you leave out the extension, it doesn't work. Extension, there's more tension there than there. And you can feel that straight away. Yeah.
A lot of people are told not to put extension into cervical manipulations, aren't they?
Absolutely, I agree. In most cases, you don't want it extended, but a little bit of extension brings the facets together. More, it's not good.
It kind of reflects, doesn't it, that when you say HVT or you say extension, people have this preconception of a massive rotation or a massive back bending of the spine, when actually this is multiplying the levers.
Yes.
Yeah, not minimising them.
No.
Well, one of the things you've said on courses with that is when you find the OA, and actually, you think it's quite difficult to find the OA?
It is in most people. If you dig up there, it's pretty sore. So if you're in the wrong place, it doesn't hurt.
Yeah, and what you said to people is if you're pressing on it, it's sore, but as soon as you put that compression in, the soreness disappears, doesn't it? The tenderness.
It's very strange. If I take the head here...
Poor old camera, he's going to be bruised.
Put pressure there. You tell me when it hurts. You're very good, you know, no pain. Is that hurting?
Not yet, maybe a little bit.
A little, there. Now, if I now squeeze the head, Now tell me when it hurts.
No.
I can dig that as hard as I can. It doesn't hurt. If you're squeezing the head, it stops it hurting. So the squeeze is first. The order of things makes a difference.
Yeah.
Yeah.
Would you be prepared to sort of just give a quick blast on a wrist and show how you might address one of
Yes.
those?
Yeah.
We'll have to stay behind the table here, otherwise we'll
yeah.
get out of camera shot. But if there's,
Turn with your feet over there. Can you still get that on camera from there? Let's have your wrist here a minute.
we're fine.
Yeah.
Do you want your glasses on?
Ah, yes, okay.
Now, in this position, I've got my hands holding the wrist there. My thumb's on top like that. That gives me a nice grip and gripping like so. And that is a very good articulation, but it's not doing anything. Now, if I squeeze laterally and that way, lots of squeeze in there. Now everything goes bang bang in there, because as soon as you put pressure on, it's going to go. It's very strange, this. I can do that all day, it won't do it. If I squeeze there and there, now it's working. Everything's creaking, banging, all over the place. And that's just simply squeezing.
Yes. I don't know where you are in your training at the moment, Cameron, but is that something you've been taught?
You've
That
been
whole-
taught sort of movements,
the whole business of compression as well.
Oh, compression as well, we've been taught.
Yeah.
too.
Okay. Yeah. I mean, it seems to be one of the things that a lot of people leave out in their manipulations, because you put in at least two forms of compression on most of your your treatments, don't you?
Yeah.
Thank you.
Great.
Shall we go and sit down again?
Right.
Now, I'm supposed to break a little bit now because I've been told that once we finish this show, everybody disappears from the online audience, and we've got a lot of people watching this evening who don't know anything about the Academy because they've been drawn by you, Laurie. So if I may, just a quick word. What we're doing this evening is pretty typical of our shows with the Academy. We provide sometimes just chat. If I'm talking to somebody about physiological factors, whatever, we might just be a chat show. But generally we try and build in the demonstrations as well, with a view to making sure that everyone who takes part in our CP